I'm Dr. Priyamvada, consultant radiologist, abdomen imaging team, KMCH. It's my honor to be your MC today. So, we are gathered here to dwell in the dynamic and ever evolving world of onco-imaging. Over the next few hours, you will hear from some of the brightest minds in our field. Their insights, research, hard work, and their clinical experience will undoubtedly inspire new ideas and foster good collaborations and help us fight cancer better. We have packed an excellent academic schedule ahead. So, without any further ado, let's begin the first session of the day. So, our first session is titled as Treat and Response. For this first session, I would like to invite the following chairpersons: Dr. Karthikeya Selvi, Senior Consultant, Adya Cancer Institute, Chennai; Dr. Madhu, Professor and Head, Kidwai Memorial Institute of Oncology; and our Dr. Vignesh Chandakumar, Senior Consultant Oncologist, KMCH. The first speaker of the session would be Dr. Vandana Mahajan. She's a Senior Consultant, Apollo Cancer Institute. Ma'am is going to talk about pearls and pitfalls of assessment in tumor response after chemoradiotherapy. Over to you, ma'am.
Good morning, everybody. So, thank you all for being here, and I thank all the organizers to giving me an opportunity to speak on the pearls and pitfalls of tumor assessment post chemoradiotherapy. So, what is the goal of the talk today? Is to emphasize the clinical importance of accurate tumor response in post treatment scenario. Now, why does the tumor response assessment matter? So it aids in therapeutic guidance to determine whether the current therapy is effective or is it failing. It helps in timely escalation or de-escalation on change of therapy. It also impacts the decision of the physician whether to go ahead with the surgery or the radiation or any other second line of therapy. And it helps in prognostication. So if there is early detection of progression, the overall survival is impacted. It also helps in clinical trials, insurance coverage in a lot of countries, and in patient counseling. And of course, it aids in research and trial outcomes by getting us a standardized criteria which can be reproducible, and we can have a comparison of all across the trials and in various institutions to have a standardized protocol for treatment. Now, what are the challenges? Now, post-treatment changes can mimic tumor, the radiation fibrosis, the inflammatory changes, and the edema. It can persist, it can increase, it can decrease over a period of time. The tumor necrosis, which can occur and appear as enhancing mass, which can confuse the doctors as if there is a residual disease or any increase in size. And chemotherapy and radiotherapy itself can induce a lot of side effects which can mimic cancer and mask the actual disease status. Immunotherapy, which Dr. Atul is going to talk about. And then there is also something called an anatomical and a functional assessment conflict. So what is that? Is that the morphologic, that is the size-based criteria, may lag behind the metabolic or the vascular changes which actually happen in the disease. So we need a gamut of investigations like CT, MR, PET imaging, diffusion, perfusion. All these things should be used in conjunction to give an adequate diagnosis. As you all know, what is the timeline of the cancer care? So there is, at the time of diagnosis, baseline imaging is done, then the treatment starts, then there is an interim assessment after a certain set period of time in which you can assess whether there is any response or no response. Then you go on to the end of treatment. Again, after the end of treatment, you have another set of investigations. Then you do the imaging for surveillance. So you all know the RECIST criteria. I'm not going to deal with that RECIST criteria. We have moved a long way from RECIST 1 to 1.1. That is the updates in which is slightly better. And it has 5 target lesions, lymph node, bone lesions are better evaluated here, and they are measurable. All these things are the general standard thing, which is not going to be discussed in this talk. We all deal with the target as well as the non-target lesions. It's easier to deal with the target lesions. However, it's the non-target lesions which always pose some challenge to our reporting. So especially the ones which do not fall in the complete response or unequivocal progression. So the middle lesions are the ones which are the troublemakers for us. So an example of this is, in this you can see an ovarian carcinoma, patient with an ovarian carcinoma, massive ascites, okay, in the pre-treatment scan. Now this is a non-target lesion. You can see pet avid omental thickening here. You can see small deposits in the subdiaphragmatic region on both sides, and you can see small deposits in the perigastric region. Then you can see small nodes here. Now, post-treatment, there is a partial response, is how you will say, with most of the lesions in the omentum, subdiaphragmatic deposit, everything seems to have disappeared, excepting the ascites, which have significantly come down but not gone. So this is non-progressive and non-complete response of a non-target. So we have to deal with a lot of tumors. So the solid tumors, either you deal with them with the PET CT or CT. If you do CT MRI, then you have to go in for the tumor specific criteria for assessment. So the tumor specific criteria, including GIST for TOEIC criteria for GIST, the modified RECIST for HCC, as well as mesothelioma, likewise, so forth, which is again a long thing. So what I'm trying to say is, you should know what criteria you have to assess the response with. You cannot assess the response of a tumor which needs TOEIC criteria. You cannot assess it with RECIST, because you will have a wrong this thing. So for an example, I will give you, so this is a HCC pre-TACE and post-TACE. So ideally, you can see in the pre-TACE or the pre-treatment, you can see an enhancing lesion in the arterial phase, venous phase, it becomes ISO. Here, post-TACE, though the size has increased, but you can see there is no enhancement, only total lipidol deposition is seen in this case. Then persist is used for PET response. So another example, a case of a 12-year-old child with an osteosarcoma in the distal tibia. You can see at the pre-treatment initially, how much is the PET SUV is very high. It's somewhere around 12. And in the interim scan, it has significantly come down to less than 2. And post-treatment, end of therapy, you can see it has come down and it is near stable to 1.7 centimeter SUV. So you have to follow each tumor according to what we are going to see. TOEIC criteria again deals with two things which are very important in this. This is done for GIST. You have to see the size as well as the initial and the later Hounsfield unit values, because the necrosis component, most of the therapies cause central necrosis. So as you can see here, the size of the lesion has come down to more than this thing. From 16 centimeters, it has come to 10 centimeters. So it is more than 10% reduction in size and 15% reduction of the Hounsfield unit. So that means the therapy is working. Immunospecific therapy, which Dr. Atul is going to deal. Now I move on to the pitfalls. So what happens when the response is deceptive? So there are a lot of radiological traps. So one of them is misinterpreting the treatment-induced changes as progression or a poor response. So a patient can present with the persistent mass on imaging. Why does this happen? Is because the tumor shrinkage persistently lags behind the treatment. Okay, there can be fibrosis which also presents as mass, and it can persist for a long time. So we normally use a RECIST-based criteria, but please keep your minds open. So an example is in carcinoma of rectum. So you can see pre-treatment scan, there is a semi-annular growth in the mid-rectum here. Significant wall thickening is there, significant diffusion restriction, significant ADC values. Post-treatment, you see the mass has significantly come down, but it still persists. However, there's hardly any diffusion restriction, and the ADC is also not there. The colonoscopy was done for this person, and it showed only a residual scar. There was no tumor in the thing. So please remember, in spite of this having showing a mass, it's just a fibrotic lesion which is. Now, you can also call recurrence due to inflammation or edema, which is very commonly seen. We come across a lot of cases when you see so much of inflammation and T2 flare hypertensity is seen, then you do not know whether to call this as a recurrence or as only edema. In that case, please compare baseline, interim, and follow-up scans are important. Look for contrast enhancement, perfusion parameters, and longitudinal stability, whether it is there or not. Also, to call it as a pseudo progression, please check the timeline. Very, very important. So here there is a case of a young female with carcinoma breast. She was treated in 2015 with chemotherapy, mastectomy, and radiotherapy to the chest wall. She was all right for 6-7 months and presented again with the cerebral metastasis. So you can see a lesion in the posterior parietal cortex here, which is enhancing. She was treated with CyberKnife in September 2016, and follow-up scan shows near total resolution. Hardly anything is seen, so far so good, she's doing well. Another year down the line, she presented with a focal seizure. Scan was done, and you can see again diffuse edema, which is more than what was seen in the prior picture itself. So you can see in another lesion, which is seen here. Now this lesion showed peripheral enhancement against central necrosis, and the lipid active peak was high when we did the scan. So in this, if you see a thing like this, please remember any enhancement pattern which follows Swiss cheese pattern. Okay, as you can see here. So this is very this thing of radiation necrosis which happens, and believe me, radiation necrosis can occur at any point of time, from 2 months to so many years. Also it can present. I have had patients which are there after 12 years presenting with radiation necrosis. The bones also undergo radiation injury. So this patient of carcinoma breast, post-treatment, post-mastectomy, post-radiotherapy, presented with the swelling in the chest wall. So there was a doubt whether this is recurrent metastasis or this thing. PET also showed diffuse uptake. The biopsy showed osteoradionecrosis. Another very important thing is radiation hepatitis. So you see, this is a case of carcinoma, OG junction, treated with concurrent chemoradiotherapy. Patient was doing well. A follow-up scan showed an increased uptake, an ill-defined lesion, and an increased uptake in liver. Biopsy was done. Again, this came out as radiation-induced necrosis. It came in the radiation field. Please do not forget the other organs get also injured. Now, another common pitfall which we have is interpretation of low ADCs as a viable tumor. Please remember, always low ADC value does not mean a viable tumor. Yesterday also, Dr. Shilpa had put up one case like that. So here I have one patient who was treated for squamous cell carcinoma. On the right side, the patient came for a routine follow-up. I picked up some low ADC value and increased diffusion and low ADC value in the opposite side, but it was significant because the patient complained of just swallowing difficulty. I was not sure whether this is, it appeared deceptive. There was some bit of enhancement also, so I made them do the biopsy, and unfortunately, or fortunately for the patient, it came out as just inflammation. Then radiation recall pneumonitis, that is the lung injury, very common. Please do not misinterpret this as recurrence or metastasis. So you see, this is a patient who was treated for Hodgkin's lymphoma, and this is the radiation field. Post radiation, you can see pneumonitis settling in on both lung fields, and post 4 weeks of steroid therapy, this improves. This is again radiation induced damage. So you can see a large posterior mediastinal mass. This came in the radiation field. So you see, this is typically involving the radiation field where it was the mediastinal mass seems to have disappeared. Now, post-radiation fibrosis can also mimic the mass. So you see, this is another patient who had treated for carcinoma breast with BCS, and 5 years later, she comes back to us with the swelling, and she feels it's more harder than the earlier what she has been feeling. So we did an MRI. You see the seroma. There is some fibrosis and scarring here. At the 6 o'clock, this again, there was hardly any diffusion restriction, no enhancement excepting the peripheral enhancement of the seroma. We again biopsied this, and it came out as only inflammatory changes. The other common pitfalls include mucinous tumors, treatment-related side effects. There can be inter-reader variability, and there is, of course, some limited data for some tumors. So for just last of the assessment, so you see a mucinous tumor, which also happens too often. So you see this is a large rectal cancer, totally mucinous, very few solid components here. Post-treatment, hardly any response, it is still persistent. So when we did they had to go ahead with the surgery. Of course, the response was not adequate. There was still tumor, and these are the tumors which again pose difficulties for the radiologist. You have some special considerations. Don't forget that pleurodesis is done for malignant pleural effusion. So when you do the pleurodesis, please keep the history in mind, because the pleural thickening secondary to pleurodesis can take FDG uptake. Remember, only 10% of the pleural malignancies will have calcification, so please take the history properly. Another special consideration is for GCSF. So every time there is a support given for this, you will see there is an increased uptake, which happens in the spleen. That does not mean that the spleen is infiltrated the lesion, but it is just the GCSF doing its work. So you can see a homogeneous uptake in the skeletal system also. Now, few pearls to outsmart the pitfalls. Please always compare with the baseline. Do not forget the baseline. The baseline is the original. Whether it was 3 times before or 2 times before, do not forget. So sometimes the lesions are too small to measure. So you see a case of adenocarcinoma of the stomach. We had 2 liver lesions to begin with. One was in segment 6, one was in segment 4. So post the treatment, they had become too small. According to the RECIST criteria, do not just say sub-centimeter. Please assign a value, if you cannot measure it, to 5 millimeter at least. Use functional imaging, it adds confidence. Please use diffusion, PET-CT, MRI, whatever you feel is important, please use. Sometimes it's not possible for us to give you with a single image. Now this is very important, which happens. So this is a case in which a CA breast patient, the vertebra looks all right, near all right on the pre-scan. You can see there's hardly any lesion or in that. But post-treatment, you see there is a sclerosis. If we had gone only by the CT criteria, it appears false progression because sclerosis has come up. However, the PET-CT in the initial phase also had picked up a marrow lesion, and the PET uptake had come down. So please remember, any new lesion means progressive disease, but all new lesions are not progressive disease. So keep your eyes, ears, and mind open. Consider the time window. I've been insisting on this. It's very important to omit pseudo-progression. Again, here there were a non-target lesions, multiple lesions in a melanoma. Tiny lesions were seen. We followed it up. We were not sure whether these are metastatic, non-metastatic, and over a period of even on treatment, this patient progressed because you can see the frank increase in size of the lesions over a period of 8 months. Please correlate clinically or biopsy, which happens most of the times. It's very important to be in sync with your physicians. Consider tumor markers, consider the patient, and do a repeat imaging if required. So this is another patient, bilateral breast carcinoma. You can see fibrosis everywhere. Patient had no complaint, just a follow-up, and then nodular thickening is all she had. So we thought there is hardly any ADC value, there is hardly any diffusion, there was hardly any contrast enhancement. But it was just on the hunch that we thought we will do a biopsy because the patient had only one problem, that she felt that the nodularity is increasing. But since the breasts are big, the thickening is there, so we went ahead and we found that both the breasts had recurrence. And most of the times, yesterday Dr. Shilpa had also said, please think out of the box. Okay, so this patient, carcinoma of the vocal cord, was treated in Cancer Institute, ADIA 1992. And he was doing pretty okay. He developed bilateral adductor palsy, for which tracheostomy was done in 2018. Now he just presented with a painful right-sided swelling. So 1992 to 2025, it is so many years. And then we figured out that he's got osteoradionecrosis of the vocal, the thyroid cartilage, and all the cartilages, in fact. And then they biopsied him, which came out as inflammatory necrotic issue also, or tissue. And then he started bleeding. So he had developed a small pseudoaneurysm. The aneurysm was clipped. The patient developed, the aneurysm was stented. Post-stenting, he again developed another aneurysm beyond the site. Anyway, he's still doing well. But these are the challenges which you will face. One of the doctors also thought if it is a recurrence or a new cancer in the field. But this is how the thing is, that post-radiation necrosis, which is what I was trying to tell you, can occur at any point of time. So we have to keep our minds and thoughts always open. So a smart radiologist is a confident clinician. Please understand and use a standardized reporting criteria like RIST. MRI is very important for assessing tumor response, to focus changes on tumor size, extent, and signals. Okay, please use DWI and ADC values wherever you can. Use them for finding out the residual fibrosis, inflammation, and improving the accuracy of your response assessment. FDG PET is for functional imaging. It helps in detection of treatment, and it aids earlier detection because of earlier morphological imaging. You can identify poor responders so that you can have a treatment rescheduling, whether you want to change, escalate, or alter the therapy. Thank you for your patient listening.
Thank you, ma'am, for your comprehensive presentation. Your expertise on the topic was deeply appreciated. We could save the questions for the end of next talk. I now invite Dr. Atul P. Shinagre. Sir is the Vice Chair of Clinical Radiology, Brigham's Women's Hospital, associated with Mass General Hospital, Boston. Sir is going to talk about the pearls and pitfalls in assessment of tumor response after immunotherapy.
Good morning, everyone. So that was great talk, Dr. Vandana. So this is a kind of natural follow-up to that talk. I'm going to focus more on immunotherapy, no relevant conflicts of interest. So we know that anti-cancer drugs can be conventional chemotherapy, hormonal therapy, molecular targeted therapy, thank you, or immunotherapy. And of course, this talk is going to focus on immunotherapy. So the objectives, we are going to keep it very simple. First 5 minutes, we are going to talk about principles of immune checkpoint blockade, because if you understand how it works, then we can understand how the response assessment and even toxicities work for that matter. And then rest of the time, we'll focus on response assessment. And we try to do it in a case-based fashion so that you're going to use the lessons learned in the reading room. So first, let's look at the concept of therapeutic index. And in very short, basically, if you try to kill cancer cells, you are inevitably going to harm some normal cells. And if you try to kill a lot of the cancer cells, you're going to harm more and more normal cells. And that's why conventional chemotherapy is so toxic. With targeted therapy, these curves are separated, and that means even if you try to kill many of the cancer cells, you're harming relatively few normal cells. These drugs also have their own toxicities and adverse effects, but they are few and relatively milder. So if we talk about molecular targeted therapy, we should understand this signal pathway. Again, very brief. This is not a detailed review. This is just a quick overview. We can have growth factors like VEGF will attach to the extracellular part of the transmembrane protein, lead to intracellular cascade that will essentially lead to cell proliferation, migration, and invasion. So we could block this by drugs like bevacizumab that will act extracellularly, or intracellular small molecule drugs. So if you have a monoclonal antibody, that means it's going to act outside the cell, either in the cell in circulation or on the cell surface. Or you could have a small molecule inhibitor. Those are typically ending in IBS, and those act intracellularly. Now, immunotherapy works differently. And so we'll quickly visit this cancer immunity cycle. So in theory, when tumor cells die, like how immune system should work against cancer. When tumor cells die, they release these cancer antigens into bloodstream. They'll be picked up by the antigen-presenting cells, carried to the lymph node where they will be presented to the T cells, where T cells will be educated to recognize this antigen and start to attack it. Then these T cells will go through the bloodstream into the tumor. Inside the tumor, they'll see this antigen, say, hey, this is something bad. They're going to start attacking the tumor, kill the tumor cell, release more antigen. This is how it should work. In reality, that's not how it works, because there are two sort of main inhibitory mechanisms. One happens in the lymph node, that's body's defense mechanism. Two, cancer cells are smart. They have their own defense mechanism that happens in the tumor. So what happens here in the lymph node? So what should happen is T cells should recognize this antigen, attach to the antigen presenting cell, and learn to recognize this and get activated. So these potentially T cells should go and start attacking cancer. But what if they mistakenly take up, because normal cells are dying every day. So what if they learn to attack a host antigen? Now that would be a problem, because that could lead to all kinds of autoimmune disorders. So as a protective mechanism, body has this CTLF, like these T cells have CTLF4 receptors. When they bind to this APC, they will inhibit the T cell. So this is body's own protective mechanism. But what if we could somehow engage this receptor? If we could block it by a drug like ipilimumab, those are anti-CTLF4 antibodies, then this interaction will proceed and T cells will get activated. So that's why a drug like ipilimumab lead to generalized activation of T cells. That's why they also have higher incidence of side effects. Now let's see what happens in the tumor. Now these activated T cells, they should recognize the antigen and then start to attack the cancer cell. But the cancer cells are also very smart. They produce something called PD-L1. Now this receptor will bind with PD-1 receptor on T cell, and that will inhibit the T cell. So this is cancer cells' protective mechanism. But if you could block this interaction by either PD-1 inhibitors or PD-L1 inhibitors, then the T cell is free to attack the cancer cells, and that's how these drugs work. Now, we could attack like this part or this part, either separately or together. So there are many combinations of ipi-nivo. It's used for many different cancers. So that will have more effectiveness, but also more toxicities. All right, so we spent about 5 minutes talking about that. Now let's talk about the response assessment. So this was the first paper in melanoma that essentially changed clinical practice. This was the first time the work on immunotherapy has been going on for a long time, but this is where the clinical practice actually changed. And now it's used in pretty much every cancer. Now let's take this example of 59-year-old woman on melanoma. This was very early after immunotherapy became available. There was no response assessed, like immunotherapy-related response criteria. So baseline, there was this mass. At 3 months, the mass grew. Now what do you do? Now, how do you assess this? Would you call this CR? PR, stable disease, PD, or not sure. So let's very quickly, and this has already been covered in the previous talk, I'm going to keep it very brief. We know that for RECIST 1.1, we take the sum of longest dimension. If it's a lymph node, we take the short axis. You take target lesions, you add it up, that's SLD. And then you have these CR, PR, PD, and SD, depending on whether it's at least 30% decrease or at least 20% increase. And then essentially what you're doing is you're taking the sum of longest dimension, and if there's at least 30% improvement, we call it PR, you track it serially, you look at the nadir scan. Now, if you just see one little bit of increase, you're not going to call it progression. But if you do see at least 20% increase, that's when you call it PD. So in the reading room, if you're just comparing one time point with the one before that, do not use the words like progression or response, because they mean something very specific. Use those words only if you are actually systematically having target lesions and tracking them progressively. Then you can use those words. So just something to keep in mind. You have to use these words carefully. So back to our patient. So there are some helpful hints that we can look at, like how long has the patient been on immunotherapy? What about the margins? Do the margins look indistinct? Is there haziness around the lesion? Is there any heterogeneous hypodensity inside the mass, which we see here? Is there differential response? Are there other sites that are responding and this one is growing? Do you see any adverse events happening? What's the clinical status of the patient? Tumor markers, wherever available, of course. And now increasingly there's a reliance on circulating tumor DNA, PD-L1 expression. Those, of course, we don't routinely see in the reading room, but these other factors is something we can see on imaging. So in this patient, at 5 months, there was nice response. But by then, this was already called progression here. At the time, patient was taken off treatment, and despite that, it showed nice response at 5 months. So we need to understand how immunotherapy works. What are the common patterns of response? So first is stable disease. Second is decreased size of lesion. Again, very simple is response. Like in this patient, again, there's a big mass. Now there's decreased size, decreased amount of solid enhancing tumor. Sometimes there's initial increase followed by decrease. Like in this case, there's clear-cut increase and then it started responding. This patient with lung cancer, the dominant mass is responding well, but then there's something new happening here in the chest wall. Is this progression? And then at a month later, because we wanted to confirm what's happening, a month later it disappeared. So these are couple of the atypical patterns of response, either initial increase followed by decrease or new lesions. So we need some kind of formal response criteria to assess this. So we know that RECIST 1.1 is most commonly used TRC. There was IRRC, then there was IR-RECIST. Both are not used anymore really. So the most commonly used tumor response criteria for immunotherapy is IRECIST. And it works very similar to RECIST 1.1. You need dimensional measurement, same size threshold, same 5 lesions total, 2 per organ. The only difference is that if you see new lesions, or if you see at least 20% increase, you do not call it progression, but you say unconfirmed progression. The idea is you think it's progression, but you want to confirm it later, which you do by doing another time point at 4 to 8 weeks. So this should have been called, ideally, unconfirmed progression, and then patient would have stayed on treatment, and the next time point would have shown that this is actually a good response. Let's look at another patient of RCC on ipi-nivo combination. Now here, what's happening? Would you call this CR, PR, SD, PD? I think here is pretty obvious. There's a decrease in size, decrease in amount of enhancing solid tissue, same thing happening in the liver. So this is good response. Same type of clinical picture, RCC on ipi-nivo. Now what's happening here? We have multiple lesions which are showing significant growth. Now what are we going to call it? Are we going to call it PD? If you know this patient is on immunotherapy, we would not call it PD. Even if it shows pretty massive increase, we are going to call this unconfirmed PD. Now, the more obvious the increase, the more likely that this is true progression. So there's a very high chance that this is true progression. But at this point, we'll still say, okay, this is unconfirmed PD. So that's what was called, and later, great response. So sometimes at this time point, it's really hard to predict how the tumor is going to behave. So how frequently does it happen? When we say pseudoprogression, what's the frequency? In melanoma, very high. A study showing 6 to 15% rate. What about other cancers? In solid tumors, it's pretty rare. 20% increase in size, so that's like true pseudoprogression is quite rare, only 1 to 2% of patients. However, mild increase in size, 10 to 20% increase, so something in the reading room, you see prior study, next study you see increase in size, which is not quite 20%, but still it's noticeable. That's pretty common. Well, how common? We looked at 254 patients, out of which 166 had some clinical benefit, SD, PR, or CR. And of those, about 20% had atypical response pattern. Only 1% had actual pseudoprogression, which met 20% threshold, but mild increase in size was very common. Same thing, like I have a little bit more affinity towards GU cancers. Same 23% of GU cancer patients had mild increase in size, but none of them had 20% increase. So the point to keep in mind is when you're looking at these patients in your reading room, you will now and then see increase in size, but no matter what, first time you have to, like if you see increase in size, you have to confirm it at another time point 4 to 8 weeks later. So let's take this case. This is a little bit unusual. So patient with RCC on nivo, increase in size, at this point was called unconfirmed progression. Increase further, at this point it was called progression. I think that was very appropriate. And then later it showed great response. So again, it's a little bit unpredictable sometimes. So patient was doing fine, then a new nodule popped up at 56 weeks. Now again, do we call it progression? Maybe not. Let's wait and watch. It increased in size. So again, it was called progression, and again, it disappeared. So sometimes this kind of fluctuations happen. Now, of course, this is uncommon. This is rare. So again, if you're in the clinical practice, you have to use systematic approach. First time we call unconfirmed progression. Next time we call, if it grows, you can call it progression. But sometimes these delayed pseudoprogressions happen, something to be aware of. Now, how about this patient with melanoma on AP-nivo combination? Again, increase in size, we are not going to call it PD, we will call it unconfirmed PD, and later on, another example of pseudoprogression. In this case, there was a new lesion, same question, we are going to call it unconfirmed PD, and in this case, the nodule did not disappear, it's almost the same size, so it kind of remains unconfirmed PD till either it grows or it disappears. So you may have 2 or 3 time points with unconfirmed PD. And it could be on CT, it could be on MR, it could be on PET CT, same thing, unconfirmed PD, but 6 months later it got better, and same. So how do you approach this in clinical practice? First thing, you have to know that patient is getting immunotherapy, otherwise you will never know what to do. Second, if there's increase in size, confirm progression at 4 to 8 weeks. Check patient's performance status or tumor markers if available, because that's a very helpful correlation. And always communicate with your oncologist, because they have a real good sense of how the patient is doing, actually doing, because they see the patient, talk to the patient, and that discussion is super helpful. Now, there's some interest in using radiomics as a biomarker. In urothelial cancer, there was a small study from our institute. It showed good performance of radiomics for identifying those patients who will progress early or late, before 12 months or after 12 months. So for example, 2 patients with pelvic lymphadenopathy, one of them did really well, the other one did not. And radiomics was able to sort of differentiate between the 2. Same thing, we had another study in RCC patients, and we could predict long-term survival on baseline CT and at first follow-up. Again, you have to keep in mind that these are small studies, these are not validated, this is not ready for clinical practice. But there is some encouraging data in these cancers and several others. So maybe in the future we could use it. Now, this patient with melanoma was on AP, routine restaging. Now here you see the lesion slightly increased in size, but you see the density is decreased, the margin is very well defined, it looks like response. But at the same time, there's something very, very tiny happening here. Is that a new lesion? So there's some confusion. You're leaning towards calling it like response, but because of increasing size, this new focus, you're a little bit confused, look elsewhere. Are there any other lesions that are responding? Or other areas of the body? Like, for example, in this colon, this fluid-filled colon, this is mild colitis. And anytime you see IRE, immune-related adverse events, this is kind of sometimes a biomarker of response. And those studies have shown that patients with IRE have higher response rate, longer PFS, longer overall survival. Another example of, again, melanoma patient, similar situation. And here, there is segmental colitis, but you'll see the tumor implants have almost completely disappeared. So this patient also had segmental colitis with complete response. Another melanoma patient on AP, this time on PET at baseline, there was nothing. But at 3 months, you see tiny lung nodules, mediastinal lymph nodes, splenic uptake. At this point, it was called progression at outside institute. But then at 6 months, everything disappeared. So what's happening here? This is sarcoid-like reaction. This is best known with EP, but can happen with other drugs. Most commonly involves mediastinal lymph nodes, pulmonary nodules, splenic involvement, but can have other areas of involvement as well. So this is important because this may sometimes mimic progression, but really this is just something that happens with immunotherapy. This is another example. So there was this adrenal metastasis. At 3 months, there was nice response. But then there was newly increased epiphrenic lymph nodes, mesenteric lymph nodes. So there's a little bit of question, okay, is this progression? But not sure. So if you see mild increase in size or some vaccine waning in size of lymph nodes in multiple areas, especially mediastinum, mesentery, those are not in direct drainage pathway of your malignancy. And if you know the patient is on immunotherapy, do not even call it unconfirmed PD. Say that this could be sarcoid-like reaction. On the other hand, if you see 1 or 2 lymph nodes which are round, which are progressively growing, those you can say, okay, this might be progression. So this was sarcoid-like reaction, and at 6 months, again, the response persists, but these lymph nodes have again decreased in size. They may fluctuate over time, but nothing to worry about. Now, this patient had bladder cancer and presented with abdominal pain. And this was pancreatitis, lipase was elevated, drug was stopped, steroids started, pancreas is a little bit atrophic on follow-up, but pancreatitis resolved. But why am I showing this case? Because there was not a lot of disease burden, just tiny lung nodules, few lymph nodes here and there, but the response persisted well after stopping the drug. So sometimes response of these drugs may continue even after stopping the treatment, and so does toxicity also. Mild toxicities may also continue, but we are focusing on the response part. So basically, in summary, atypical response patterns may be seen with immune checkpoint inhibitors, either initial worsening followed by response or with new lesions. RECIST 1.1 and iRECIST are tumor response criteria of choice, and it's important to confirm progression at 4 to 8 weeks. Delayed pseudoprogression or delayed response are possible, but of course rare. IRAs are a biomarker of response, and then response often continues after treatment is stopped. Thank you.
Thank you so much, Dr. Atul, for a very captivating session. The way you broke down all the complex topics with SEES was made the topic very easy and very incredibly clear for all the audience. The session is now open for discussion. Any queries?
In a scenario where a patient is on both immunotherapy and chemotherapy, do we still have to mention unconfirmed progressions?
Yeah, many times patients will be on combination. If patient is getting immunotherapy, they're subject to the same immune response cycle, same sort of response of the body. So yes, you have to consider that.
And just to clarify, the pseudoprogression can happen at any point of time. Even after 2 years, if the patient shows increase in disease, we still have to give another chance.
That's another good point. Actually, I did not include that part. But pseudoprogression usually happens early on in the treatment, first 3 to 6 months. It can happen. We have some patients, and we actually studied this. It can happen up to like 12 months or even like beyond, but it's less common. So the easiest way to think of it is, if it happens early, it's more likely to be pseudoprogression. If it happens late, it's more likely to be true worsening. And if there's a lot of increase in size, it's less likely to be pseudoprogression. It's more likely to be true progression. I hope that makes sense.
Okay, but if the clinician asks if it is progression or not after like
Then you say, I
2 years,
don't know, because that's the
we still have to give
yeah.
another
So, but
chance.
the idea is, even if it happens, let's say 1 year or 2 years later, you can say, if you're talking to them, you can say, look, I think this is really worsening because just given the time frame, but technically we are still going to call it unconfirmed PD. You need another time point, and then we'll confirm it. So your actual report does not change. Your discussion will be a little bit different.
Thank you.
Assessing factors like discussion with the clinician, as he said, it's very important to know whether the disease on the patient, what is patient's status. That is also important. Or if there are any other tumor markers, please correlate. It's not only one. We just aid. Okay, the rest is the clinician. He has the patient with himself.
Yeah, so I showed a little thing. There's several factors that you can look at, and understanding how the patient is doing clinically, the performance status, tumor markers, and like you mentioned, you have to talk to your oncologist because they have a good sense of what's happening with the patient. If there's a discrepancy, you have to be a little bit more guarded in the way you use the word progression.
Yeah, thanks, Dr. Atul. I mean, all your cases are from the clinical trials, I suppose.
No, not all of them are. Some of them are from clinical trials, and some are from just routine practice.
Okay, I mean, more and more we are seeing, of course, it's melanoma, assisi, it's fine, but it's always now, I think, oncologist is here, it's the combination of chemo and immunotherapy, and we are not seeing those kind of classical immune-related reactions, what it used to be. Of course, we do see, but the response is not heavy. Either it works.
Sir, that was the question. I also had about 12 years back when I was a student at Adyar Cancer Institute. First time when cetuximab was introduced, there was a patient who had absolutely no response to chemotherapy. We just gave cetuximab, responded. I'm not saying he is going to have durable response always. Around 20 to 30% of patients have durable response. For the past 4 or 5 years, I have been extensively using immunotherapy. Answering her question, I would say, even if you call it as progression on immunotherapy, I will call it IUPD.
Yes.
Then I will redo an imaging after 3 months, then only call it a progressive disease after taking into board, because what sir says is absolutely right. It is not that we see response early, sometimes we see late, but most often the response is early, and whoever attains early response have a reasonably durable response in around 20 to 30% of patients. What we call it as weeks, patient is going to die, we are seeing a lot of months. I at least have a double-digit number of patients on immunotherapy crossing 1 year.
Yeah.
So, and we do see good effect with low dose. So the low dose
that's
we using
exactly
is 20 mg also, not even 40 mg. It makes sense, 40,000 per month instead of 2.2 lakhs. And we are able to give more number of cycles with durable response in around 20 to 30% of patients. It is not that immunotherapy is a waste. It is useful in about 20 to 30% of patients who have durable response.
Question. When is the imaging surveillance, what is the pattern of imaging surveillance following immunotherapy?
So it depends on the type of cancer, whether the patient is on a clinical trial, because clinical trials have their own set, we cannot really change that schedule. But if it is something like, if it's a more aggressive type of cancer, it could be every 2 to 3 months. For some, but for most commonly, first time it's 3 months, then 6 months, and beyond that, it just depends on the patient. That's at least our practice. I think in the US, we tend to over-image quite a bit. Early on, when immunotherapy was new, they were doing every couple months. And now it's shifted to 3 or 4 months. But it really depends on the type of cancer and how the patient is doing. And sir, if you have any, from your point of view.
Sir, if the patient is clinically stable, he is well, we just go with X-ray imagings. When we have a high suspicion for progression clinically, then only we go for these PET or CTs. Otherwise, we are also nowadays gaining confidence just going on with X-rays. The minimal changes we ignore. As far as patient is stable, then we don't do over imaging.
That makes sense. And I think even at our centers, there is like a little bit more comfort level of getting like less imaging. So over the years, we have seen a little bit of change in practice, but I think we still tend to over-image. And sometimes patients want it. Patients push to get a CT scan to make sure nothing's changing. And it can be avoided. At least some of those scans can be avoided.
I think it also depends on whether the patient is in a trial or paying for out of the pocket for the whole treatment.
I'm in a corporate where everyone is spending from the pocket. We see response.
Yeah.
We see.
So I have one question for you, sir. Supposing if I write that there's a new lesion coming, even though we know that this could be unconfirmed progression, would you do lymphocyte assessment or do you ask for a biopsy just to make sure things are on right path?
No, sir. We most often ask for a repeat imaging, short follow-up imaging within the next 8 to 12 weeks, and we get the answer most often. In spite of that, we are not sure, then you go for biopsy.
Yeah, I agree.
Thank you all for a very engaging discussion. Thank you, Dr. Vandana and Dr. Atul, for starting the day so graciously. So in continuation with the topic proper treatment response, let's go through the treatment-related toxicities. So for the first talk, we would like, thank you to the person, sorry. For the next session, I would like to invite Dr. Dayal Sundaram, consultant radiologist from Apollo Hospitals, Dr. Shivkumar Swami, head and director of radiology, HCG Hospital, Bangalore, to chair the session. And for the first talk, it's going to be given by Dr. Subha Degumati, the clinical investigator, assistant professor of radiology, Mass General Hospital, Boston. Sir is going to talk about the treatment-related toxicities of thorax.
Good morning again, and thanks for inviting me. These are my disclosures. I'll be talking about treatment which is regional and systemic. In the regional treatments, I'll talk about few surgical complications of radiotherapy ablation. And systemic, I'll talk about chemotherapy, targeted therapy, and immunotherapy. The surgery for lungs is divided into anatomical surgeries, non-anatomical surgeries. For most cancer resections, this has to be anatomical resection. When you talk about anatomical resection, you take out the lung along with draining lymphatics and its blood supply. It is usually segmentectomy or it's a lobectomy, more commonly. The commonest complication of this procedure is air leak, pneumothorax, bronchopleural fistula. To avoid these complications, the surgeons usually wrap the bronchial stump with some other material. The common things would be intercostal muscle flap or a pericardial patch or a muscle flap from chest wall or sometimes diverting omentum. By doing these procedures, they reinforce the blood supply to the bronchial stump, therefore preventing the complications of dehiscence and stump blowout. But the problem is, when you do these additional procedures, the postoperative bed looks different. You have to be careful in recognizing this, and this may cause make you overdiagnose recurrence, or it may cause delay in diagnosis. So this is one case. After placement of the intercostal muscle flap, the recurrence was not recognized and became a much more aggressive cancer later on. The other procedure which is done is lumenectomy. This is a much rarer surgery. It has higher mortality rate, around 7%, where the entire lung is removed. This is usually reserved for central tumors or the tumor is involving multiple lobes in a lung. The complications are, you have to understand the post-operative appearance of the pneumonectomy space. It has got a pleural rind. You should know the thickness of the pleural rind. If the pleural rind becomes asymmetrically thick, it becomes nodular. Think about a complication, such as hemothorax, recurrence of the tumor, or it could be infection. The another rare complication which we see following lobectomies, but more commonly after pneumonectomy, is stump thrombus. This is a localized clot right at the anastomotic site or ligation site of the pulmonary artery. The important thing is this should not be confused with tumor, and this is not thromboembolism. The reason I tell you this is that there is little controversy regarding anticoagulation in these patients because this is not an embolic phenomena. If the anticoagulation is associated with serious complications, the surgeons would rather not do anything. The other complication is pneumonectomy syndrome or post-pneumonectomy syndrome. It usually happens after right-side pneumonectomy. The left lung hyperexpands, and in being hyperexpanded left lung, it pushes the heart and mediastinum to the right pneumonectomy space. This causes pinching effect on the left main stem bronchus. This causes airway obstruction. The patient can have significant respiratory compromise. The treatment for this is to shift the mediastinum and heart back to the midline by filling the pneumonectomy space with fluid or breast implants. So this is a procedure which is done, and this is a rare complication, but it's important to recognize this complication. There are several types of pneumonectomies. I'll show you simple pneumonectomies. This is an intrapercardial pneumonectomy, where along with the lung, a part of the pericardium is removed. This type of surgeries are usually done for mesothelioma or for patients with thymoma and pleural metastasis, and in some rare cases of lung cancer. When you remove the pericardium, it is important to repair the pericardium. You repair with synthetic material, and one complication of this type of procedure is if there is a dehiscence of the patch, or if it is not done properly, the heart can herniate through a pericardial defect and it can have torsion. This is an important surgical complication, so you should be aware of these things. The another procedure which is done is talc pleurodesis. This is a common procedure done in our hospital for malignant pleural effusions when the fluid is accumulating very rapidly. The purpose of talc is induce sterile adhesive pleuritis. To do this procedure, it's usually done under general anesthesia by VATS, thoracoscopic procedures. We drain the fluid and you spray the pleural surface with talc. All this white material on the surface of the lung, pointed with the red arrow and the asterisk, that's the talc. It induces the inflammatory response. But there is a rare complication with this type of procedure, that is diffuse alveolar damage and ARDS. This is a rare complication, but this can happen in elderly people, and if the lung has underlying interstitial lung disease, and this type of complication can be fatal. As pointed out before, when we do talc pleurodesis, that induces slow inflammatory response that can go on for months to years. When you do FDG PET imaging on these patients, there can be increased FDG uptake. This should not be confused for pleural disease. Now we move on to radiotherapy. There are several types of radiotherapy. I'll just focus on two types, 3D conformal therapy and SBRT. The 3D conformal radiotherapy is the standard where you use 3D images from CT to reconstruct in axial, sagittal, and coronal planes. Then you use radiotherapy beams. You map out the tumor by computers so that the maximum dose is given to the tumor and the normal tissue is spared. To do this one, if you're using IMRT, we can use multi-leaf collimator to focus, narrow your radiation beams. After radiation, the lung undergoes changes. The lung will have early changes, late changes. The early changes include pneumonitis, which is histologically diffuse alveolar damage and injury to the pneumocytes. This usually continues for up to 4 months, then it stabilizes. It can be seen within few days to a few weeks, and it stabilizes after 4 months. Then we go on to the late phase, which is fibrosis, which is histologically fibroblast proliferation, and it also has got organizing component of diffuse alveolar damage. It progresses over 6 to 12 months and stabilizes after 18 months or so. Sometimes this response can be very, very profound. The patient can become very sick and the treatment becomes difficult. Though we with steroids, the response may not always be good. And this can also be FDG avid. The other effect of radiation is in the lung is organizing pneumonia. This organizing pneumonia can develop in the lungs even if the lungs were not in the field of radiation. This is an example of a patient who had a breast radiation years ago, then started developing this organic pneumonia in the lung. The more common treatment effects of radiation are pleural effusion, pericardial effusion. We usually see some amount of effusion. This should not be confused for pleural metastasis. Pericardial effusion again is very common. This should not be confused for pericardial disease. And radiation-induced prostatitis, radiation-induced fractures are also common. They should not be confused for metastasis, especially if PET is done in these patients. These may be FDG avid. The more common or serious toxicity of radiation would be on the hollow viscous, such as esophagus. The esophagus can have intense mucositis, esophagitis. It may result in severe odonophagia. It may cause strictures, like we see on the top image here. It may result in fistula formation. This is particularly common for bulky mediastinal lymph node neuropathy radiation in the setting of small cell lung cancer. It may create fistula between the esophagus and airways, or in this case, there's a fistula between the posterior wall of the esophagus and the pleural space. Unlike the regular MRT, SBRT, which stands for stereotactic body radiotherapy, is a high-intensity photon therapy. The dose is delivered in fewer fractions, usually between 3 to 5 fractions. And because it is such an intense dose delivered in a short period of time, they plan it very carefully so that the normal structures are spared to a greater extent. The findings which evolve, what we see after SBRT is slightly different. We tend to see more mass-like formation of the treated tumor. It may look like a recurrent tumor, but please be aware, this is all intense mass-like response after SBRT. The recurrence is difficult to diagnose in these patients if you're not aware of the evolution of the findings. When you see convex borders, or if you see growth in the treatment zone after its stabilization, or when the patients, when you look at these images in sagittal plane, you see growth in the craniocaudal direction, think about recurrence. The ablation therapies I'm only showing you to demonstrate the post-treatment changes. When you ablate lung tumors with thermal ablation, and be it microwave, radiofrequency, or cryoablation, the tumor or treatment zone evolves in a predicted fashion. So initially, there will be an increased size of the treatment zone with reverse halo, cavitation. This should not be confused for infection or abscess. And it takes some time for the changes to resolve. But finally, for a small tumor that is treated, you may leave a scar which is much bigger. When you do FDG PET imaging on these patients, again, the appearance can be not so helpful, because up to 6 months, there can be increase in FDG activity because of surrounding inflammatory response. We may see or may not see the central photopenic area. Now we move on to the more interesting stuff of drug-related pneumonitis. I want to start off with a patient. This patient was 68 years old. Our patient was on everolimus. It's a mTOR inhibitor. The patient was being treated for RCC. The patient over the last few weeks developed chronic cough with brown sputum, also had weight loss. Interestingly, the patient went to Ghana to attend her daughter's funeral. Now she came back to the hospital when we did the chest x-ray. There were patchy consolidative opacities in the lower lungs and in the anterior aspect of the upper lobes. At this time, we were not sure what we were dealing with. We had a CT scan. The findings were non-specific. The history of travel and TV exposure, all those things were very puzzling for us. So we were not sure if this is an infection or drug-related pneumonitis. So this patient underwent bronchoscopic biopsy, and it showed prominent chronic inflammation, histiocyte aggregates in alveolar spaces. There were also some granulomas. So this was ultimately thought to be drug-induced pneumonitis. The reason I'm telling you this is, every time you see a drug-induced pneumonitis, the challenge is to rule out infection. It is not always easy. During the peak of COVID time, everything was COVID. Though we thought it was drug-related pneumonitis, it turned out to be COVID. But now when we think it is COVID, this is more likely to be drug-related pneumonitis. This patient was put on treatment holiday with steroids, and 3 months later there was very good response. So what are the symptoms of drug-related pneumonitis? The two common symptoms are dyspnea and cough. These patients can also have fever, and occasionally can also have chest pain. But more importantly, a third of these patients are asymptomatic. When you look at pneumonitis, we have to classify them into 5 grades. Grade 1, which is seen in a third of the patients, these patients are asymptomatic. The only manifestations are in imaging. Grade 2 has mild symptoms. Grade 3 has severe symptoms. But from then on, it becomes serious. Grade 4 is life-threatening respiratory compromise. Most of these patients get admitted to the ICU. Many require intubation, and grade 5 is death. Fortunately, this is not common, but we have to recognize early on to prevent a grade 5 complication. There are several patterns of drug-induced pneumonitis. We approach them by the pattern we see. If this is an organizing pneumonia, a peripheral consolidation, ground glass opacity with a reverse halo, this is organizing pneumonia pattern. This type of pattern in the lung cancer setting is usually seen with EGFR TKIs, that is the Alartinib, Gefitinib, Osimertinib. These are the ones which are EGFR specific targeted therapies. It is also seen with mTOR inhibitors. The incidence of pneumonitis is probably the highest with mTOR inhibitors, like everolimus. The incidence is around 40%. ALK inhibitors can also have to a lesser degree. The ALK inhibitors are crizotinib, alectinib, loratinib. These are the group of drugs. So these are less common, but they are very common with ICI. The reason they are common is ICIs are more widely used. Most of the drug-related pneumonitis we see are attributed to ICI, that is immune checkpoint inhibitors. Non-specific interstitial pneumonia pattern, peripheral, ground glass, consolidated opacities, bronchial dilation, subpleural sparing is uncommon. This is typically seen with ICIs and also seen with early generation, first and second generation EGFR inhibitors like gefitinib, erlotinib. Hypersensitivity pneumonitis pattern is another distinct pattern. This pattern comprises of subtle centrilobular nodules, diffuse ground glass opacities, but you have to be aware of these areas of ground glass hypoattenuation, lobular areas of sparing. This is a giveaway. This is a hypersensitivity response to drugs. This is a fairly common appearance. This is seen with EGFR tyrosine kinase inhibitors, mTOR inhibitors. It can also be, it's a prominent manifestation with methotrexate. If it is not recognized early on, it goes to fibrotic phase. It is also seen again with ICI. The fibrotic interstitial pneumonitis pattern is fortunately rare because this is almost irreversible lung damage. This is usually seen with bleomycin if not recognized early on, methotrexate if not recognized. It was also seen in early generation TKIs or EGFR, but they are not used in clinical anymore. So more commonly we see bleomycin, methotrexate. The most important manifestation you should be aware of is diffuse alveolar damage, because this type of lung injury has poor prognosis. It's very serious. It may cause death. This type of damage is seen with EGFR TKIs, ALK inhibitors, even with immune checkpoint inhibitors. So this is the most dangerous type of reaction. The reason I emphasize is, when you see this pattern, please do not think about pulmonary edema, do not call it as pneumocystis pneumonia, raise the possibility of being drug-related pneumonitis. The pulmonary toxicity of systemic treatment, we can divide into 3 categories: the conventional chemotherapy, TKI pneumonitis, ICI pneumonitis. The conventional pneumonitis, the therapy for lung cancer is usually platinum doublets. We use cisplatinum or carboplatinum with some other agent. The platinum compounds are relatively safe for the lung. Their toxicity is elsewhere. They are mostly they cause neuropathy, marrow suppression. But the taxanes which are used along with the platinum-based drugs, they have the potential to cause pneumonitis. But in general, conventional chemotherapy is pretty safe. The taxanes are paclitaxel, docetaxel, these are the drugs. They can cause pneumonitis. But more commonly, we are worried about TKIs. In lungs, there are so many different genetic alterations for which there is a targeted therapy. We have EGFR, ALK rearrangements, ROS, RET, even MET14 amplification. Every one of these newer alterations have a targeted, discovered alterations have a targeted therapy, and they can induce pneumonitis. ICU pneumonitis, either used as a solo therapy or in combination therapy, will also increase the incidence of pneumonitis. So what are the risk factors for pneumonitis? Pre-existing ILD, smoking, poor performance status, and radiation therapy, mutation burden all increase the possibility. A few points about immune checkpoint in pneumonitis. They also have the same risk factors, but in addition to these things, if you use immune checkpoint inhibitors along with EGFR TKIs, the incidence of pneumonitis is higher. Renal failure increases incidence. The other thing is, the management of this pneumonitis is, if asymptomatic, you can still continue it. If the patient is symptomatic, stop the drug, add steroids. The problem with ICI is, even after you stop the treatment, the drug-related pneumonitis can still progress because the activated lymphocytes will still continue to induce damage on the normal structures because you cannot turn them off so quickly. So it was covered by Atul, the sarcoidotic reaction. Please be aware of this entity. This is very common with lung cancer therapies, breast cancer therapies. It produces lymphadenopathy in symmetric distribution, perilymphatic nodules, and more importantly, this will not progress to systemic sarcoidosis. And importantly, this does not affect the overall survival or progression-free survival. Thank you.
Thank you so much, sir. Next, I'd like to call upon Dr. Avinash to talk about treatment-related toxicities in abdomen. Dr. Avinash is Division Chief of Abdomen Radiology, Director, Center of Research and Innovation in Abdomen Imaging, Brigham and Women's Hospital and Mass General Hospital, Boston.
Thank you so much. Good morning, everyone. It's such a pleasure to be here. Before I start, I want to thank the organizers profusely for the kind invitation opportunity. We've got great hospitality here. We want to thank them, especially Priya and Gautam. They have been too kind. Of course, Venkatesh and Rupa as well. So thank you so much. So I'm going to talk about treatment-related toxicities involving the abdomen. These are my disclosures. Unlike Suba, who has to deal with thorax as one organ, there are multiple organs in the abdomen. So I'm going to focus on immune-related adverse events in the abdomen. I'm going to review the imaging manifestations of various adverse events. So now, what are immunotherapeutic agents? I know we've already had several talks on this. These are basically targeted therapies relying on the immune system to fight neoplastic cells. Ever since the first approval of the agent in 2011, there have been multiple different types of immunotherapeutic agents which have been introduced, including both active and drugs which act on active or passive immunotherapy. This is just a list of different immunotherapeutic agents. This list is from 2020. I'm sure there are multiple more drugs available now for various different types of cancers. As the use of immunotherapeutic agents in the has been increased in oncology, there has also been increasing identification of immune-related adverse events which occur due to overactivation of the immune systems. If you look at the immune-related adverse events, these involve multiple organs. These are diverse. However, they are generally well-tolerated and less predictable compared to the adverse events from cytotoxic agents, which are more predictable, commonly serious and organ-specific. Now, if you look at CTLA-4 inhibitors, the adverse events there are more dose-dependent than anti-PD inhibitors, and combination therapies usually have more adverse events compared to single agents. Often, these adverse events resolve after discontinuation of therapy. Now, if you look at the time course of occurrence of these immune-related adverse events, they typically occur within 12 weeks of initiation of therapy. Endocrinopathies, when they involve endocrine organs, occur later and persist longer than GI involvement. The median time of resolution after institution of various therapies is usually 6 to 8 weeks, but if you look at radiological resolution of these adverse events, it takes around 2 to 2.5 months. Now, what are the different management strategies for patients who have been identified to have these immunotherapeutic related adverse events? These include withdrawal of the agents, use of immunosuppressive therapies such as steroids, anti-TNF antibody drugs. Supportive care is very crucial in management of these patients, and often severe cases need hospitalization. Usually these patients are handled in a multidisciplinary setting, and you can see the grading of by the National Cancer Institute for grading of adverse events. Depending on the symptoms of the patients, different therapies are managed. Now let's look at the variety of different organs involved by these adverse events. As seen here, you can see multiple different organs can be involved, right from the pituitary gland all the way up to the femoral head. I'm going to focus on the adverse events in the abdomen. The GI tract is the most common site of involvement, followed by organs such as adrenals, kidneys, liver, and the spleen. I'm going to start with cases and then discuss each complication. So this is a 56-year-old patient on Pembro who presented with abdominal pain. The CT showed thickening of the duodenum with periduodenal fat stranding. So this was a biopsy-confirmed case of duodenitis. So duodenitis is a gastrointestinal manifestation of immune-related adverse event on patients on immunotherapeutic agents. Now, the incidence and severity of GI toxicity is often dose-dependent on those patients who are on CTLA inhibitors. Upper GI tract involvement is infrequent, and patients often manifest with esophagitis, aphthous ulcer, or gastritis. By far, the most common manifestation in the GI tract is colitis. Small bowel involvement can be seen often when there is involvement of the colon. Isolated small bowel involvement without colitis is rare. So let's look at some examples of small bowel involvement. This is a patient who presented with small bowel terminal ileitis, where you can see that there is typical manifestations of inflammation of the bowel wall thickening, mural stratification, and perienteric fat stranding. Important to remember here that the enteric manifestations of immune-related adverse events are no different than other inflammatory conditions which involve the bowel. Another example of a patient here who presented with, I hope this video runs. Okay, who presented with the enterocolitis, and you can see there's involvement of the colon as well as the terminal ileum. So this is small bowel enteritis colitis in a patient on checkpoint inhibitors. Another example, 63-year-old man with non-small cell lung cancer was treated with PD-1 inhibitor and developed diarrhea. On the CT scan, you can see that there's diffuse thickening of the sigmoid and the rectum. There is mural stratification. There is perienteric hyperemia. There's also fat stranding, and the entire colon was involved. This patient had an endoscopy and biopsy, showed severe pancolitis with ulceration involving the rectum as well as the entire colon. So this was a typical case of immune-related colitis. So colitis, as I mentioned, is the most common GI tract manifestation of checkpoint inhibitor adverse events. It's the most common cause of fatality in these patients with a mortality rate of 1.1%. Combination therapy has more higher incidence of these adverse events compared to when patients are on single therapies. Also, you have earlier onset of disease when patients are on combination therapy. Symptoms of colitis are often seen 5 to 10 weeks after initiation of therapy, and they can occur up to 4 months after the last dose. The clinical features: patients often present with diarrhea, hematochezia, weight loss, and nausea, vomiting. Now, if you look at the role of imaging, the role of imaging is early detection, grading the severity of colitis, and also assessing for complications such as free perforation. It's important to remember that the imaging is not, the performance of imaging is moderate to poor in diagnosis of colitis in patients on immune checkpoint inhibitors. That's so the reason. What happens is, in patients who are symptomatic, sometimes imaging can be normal, and sometimes imaging can be abnormal in asymptomatic patients, where you can have only a microscopic colitis identified. Now, in patients with immune-related colitis, 3 patterns have been identified: diffuse colitis, segmental colitis with diverticulosis, and isolated rectosigmoid colitis. I want to just discuss these in a little bit more detail because this has some implications on your routine practice. Let's start with diffuse colitis. Diffuse colitis presents involvement of the entire colon. It has a non-specific imaging appearance and resembles any colitis. The patients present with diffuse colonic wall thickening, mucosal hyperenhancement. Sometimes the colon is fluid-filled. There is mesenteric vessel engorgement and pericolonic fat stranding. Just the presence of mesenteric hypervascularity has been described as an early sign without the presence of bowel wall thickening or mucosal enhancement. This is an example of a patient with diffuse colitis, which was complicated by pneumatosis and free pneumoperitoneum. Interestingly, this patient was asymptomatic, had no vascular thrombosis, was managed conservatively, and did not require a discontinuation of the immune checkpoint inhibitor therapy. So pneumatosis and free perforation is infrequent, but can occur in nearly 1 to 6% of cases. Let's look at the second type of manifestation of colitis in patients with immune checkpoint inhibitors, segmental colitis with diverticulosis. Now, this typically occurs when on imaging you have colitis which overlaps with pre-existing diverticulosis. So the patients have diverticulosis, and then you get segmental wall thickening, mucosal hyperenhancement, pericolonic fat stranding. You also see pelvic fascial thickening and mesenteric hypervascularity. As compared to the diffuse pattern, bowel wall thickening and pericolonic fat stranding are more common. Now, it is important to distinguish between segmental colitis with diverticulosis, CARD, as it is called, or diffuse pattern, because the therapeutic implications are different. While patients with diffuse colitis often present with profuse non-bloody diarrhea, patients with SCARD often present with bloody diarrhea and cramping pain. Management of diffuse colitis usually involves administration of steroids, while patients with SCARD require both steroids and antibiotics. Also, important distinction from infectious diverticulitis is that in these patients who have SCARD, usually the stool test is negative for microbes or leukocytes. Okay, this is another example of a different patient, a 77-year-old man presenting with non-small cell lung cancer, who presented with symptoms of diarrhea during anti-PD-1 therapy. Here what you see is there is involvement of the rectum and sigmoid colon with wall thickening, mild perienteric hyperemia, and mural stratification with mucosal hyperenhancement. So this was isolated rectosigmoid colitis. Isolated rectosigmoid colitis can sometimes just present with mucosal hyperenhancement without the presence of wall thickening. The perienteric changes are less common compared to diffuse pattern or SCARD, and clinical presentation can be similar to diffuse colitis. The colonoscopy is, of course, the gold standard for diagnosis of this condition. This is an example of a patient with metastatic melanoma who was on Ipi-Nivo and presented with rectosigmoid colitis. This patient had to be given steroids for management of this colitis involving the rectum and the sigmoid. Now, I won't go into details. We looked at patients who had colitis when on immune checkpoint inhibitors. I just want to focus on what we looked at, the predictive ability of multi-detector CT in patients with immune checkpoint inhibitor colitis. We tried to come up with a scoring system where we looked at 7 different features: involvement of multiple segments, mural thickening, mural hyperenhancement, mesenteric hyperemia, presence of fluid-filled bowels, pericolonic fat stranding, and small bowel involvement. For each of these 7 features, we gave 1 point, and then we tried to correlate that with the use of IV steroids and also length of hospital stay. What we found was in patients with ICI-related colitis, the severity score had prognostic value in predicting use of intravenous steroids. It also predicted prolonged inpatient length of stay, that is more than 7 days. Now, this is an important factor, because if you look at one of the quality metrics for hospitals in the United States, inpatient length of stay is an important metric, and actually has a lot of emphasis in patients go out of the hospital after they are on treatment. So MDCT plays an important role in predicting how long the patient would stay in the hospital. Also, the score correlated with endoscopic mucosal ulcerations. Okay, let's move on to a different manifestation of immune-related adverse events. This is a 59-year-old patient with ovarian cancer on Pembro. What you see here is that there is hypoenhancement of the pancreas. There is peripancreatic fat stranding. There is also mild pancreatic duct dilatation. Not sure if I can. arrow shows up here, yeah. You also see that there is mild pancreatic ductal dilatation with pancreatic duct narrowing. So this patient, we did an MRI. On MRI, you can see that there is, on the T1 weighted images, there is loss of normal T1 hyperintensity of the pancreas, and the pancreas showed hypoenhancement with peripancreatic fat stranding. So this was a case of immune checkpoint related pancreatitis. It's not a common occurrence. It's seen in 1 to 2% of cases, and majority of these patients present with features which resemble acute interstitial pancreatitis. Isolated elevation of lipase levels can be seen without the presence of imaging manifestations. Important to do prompt diagnosis is important for proper management, especially discontinuing the immune checkpoint inhibitor therapy and administration of steroid medications. Diagnosis is helpful if you look at pre-treatment imaging, which helps you identify the development of manifestations related to pancreatitis. The resolution of the radiologic features can range anywhere from 4 weeks to 20 weeks. So the imaging findings, a majority of these patients present with imaging findings which resemble acute interstitial pancreatitis. Focal pancreatitis can be seen in around 20% of patients. There have been description of pancreatitis features which resemble AIP. For example, in this case, you can see that there is diffuse enlargement of the pancreas with normal pancreatic lobulations, and if you sort of try to hallucinate, you might see a hypoechoic, hypodense rim around the pancreas. It has been described in around 5 to 10% of patients, but in our practice, we have not seen a lot of ICI pancreatitis presenting like AIP-like pattern on imaging. Often these patients develop chronic pancreatic atrophy later on, and the degree of atrophy can vary from mild, moderate, or severe. This is an example of a patient who was on Pembro. This is Pembro-related pancreatitis seen on imaging. You can see how on the PET CT you can better appreciate the abnormal heterogeneous uptake within the pancreas. These are on the fused images. This patient, 9 months later, you can see there is development of severe atrophy of the pancreatic gland. The atrophy of the pancreas after ICI pancreatitis can also lead to endocrine and exocrine dysfunction. Another example of a patient with the immune checkpoint related pancreatitis. It's a little more heterogeneous in this example, including the uptake on FDG. This is another example of a patient who was with metastatic melanoma who was on Ipi/Nivo. You can see the pre-treatment scans in June 2017 shows normal pancreas. There's development of ICI pancreatitis, and then a year later you can see that there's moderate atrophy of the pancreas. Moving on to a different manifestation, a 69-year-old male with metastatic melanoma on Ipi/Nivo. This is on routine imaging which was performed for cancer surveillance. You can see there's heterogeneous enhancement of the pancreas, of the liver. I know I love the pancreas. Everything looks like the pancreas. Heterogeneous enhancement of the liver. Is predominantly you can see hyperperfusion of the left hepatic lobe. So this was a case of immune-related hepatitis. Immune-related hepatitis, involvement of the liver can be either hepatocellular or cholestatic. Immune-related hepatitis is rare, often presenting with mild increase in liver enzymes, and usually occurs 6 to 14 weeks after initiation of therapy. Like in this example, patients who are on combination therapy have higher risk of development of hepatitis, and imaging is usually abnormal only in severe cases. In the importance of identifying this is that often these patients require steroid treatment or discontinuation of therapy. One thing important to remember is if you're looking at on CT, when you have hepatitis, when you have hypoattenuation and heterogeneous enhancement, that can make it difficult to identify liver metastasis. So often these patients would need MRI for follow-up of liver metastasis when they develop these heterogeneous liver parenchymal abnormalities. Liver biopsy is of course needed for definitive diagnosis. This is a patient with clear cell RCC on immunotherapy, had acalculous cholecystitis. There's images which demonstrate the development of that. You can see in July, this patient, the gallbladder looked normal and presented with right upper quadrant pain. The manifestations and clinical picture is similar to those where the cholecystitis is without, in those patients who are not on immune checkpoint inhibitors, and the management is similar. Different example in a patient with non-small cell lung cancer on Pembro. You can see the liver is very heterogeneous. On post-contrast images, you can see there is a discontinuous dilatation of the biliary ducts with bile duct enhancement better appreciated on delayed images. MRCP clearly distinctly shows the irregular multifocal stricturing of the biliary intrahepatic bile duct. So this was a case of immune checkpoint related cholangitis. Now, cholangitis often presents in the with the obstructive cholangitis like picture. You can see elevation of the cholestatic serum markers more commonly than elevation of transaminases. There are three different type patterns of cholangitis described: extrahepatic predominant cholangitis, intrahepatic predominant cholangitis, like I see in this example, or you can have diffuse cholangitis where you have involvement of both intra and extrahepatic system. During treatment, biliary ductal dilatation can often progress and may not regress after discontinuation of therapy. Of course, diagnosis would require biopsy, which will show T cell infiltration into the bile duct wall. This is an example of a patient who was with metastatic lung cancer on NIVO. The biliary tract was normal on pre-treatment imaging. Subsequently, you see several months later, after initiating immunotherapy, this patient presented with elevated LFTs. Serum IgG levels were normal, and you can see diffuse abnormality of the intrahepatic bile ducts as well as bile duct wall enhancement of the extrahepatic bile ducts. This is another example of a patient with melanoma on EP-nuvo who presented just with segmental cholangitis involving the segment 4 and 5 ducts. You can see that there is segmental involvement of the 5 and 4 ducts. Okay, moving on to a different patient with metastatic melanoma treated with Pembro, shows 3 different imaging time points. In October, you can see that there's development of increased FTG uptake in adrenals. And so this was a patient who had adrenalitis. Now talking about renal and adrenal involvement is rare. Interstitial nephritis is the most common manifestation. Less commonly, you see lupus nephritis or minimal change disease. Imaging description is not available. Predominantly, they present with renal enlargement. Adrenal involvement is again rare. And often patient presents with nodular thickening of bilateral adrenals and adrenal insufficiency. On PET-CT, you can see bilateral adrenal enlargement and increased FDG uptake. Adrenals often show hypertrophy after discontinuation of therapy. Sarcod-like reaction in patients who are on immune checkpoint inhibitors, Atul already spoke about it. This can have multiple different type of manifestation, including splenomegaly with splenic lesions, lymphadenopathy in the abdomen or mediastinum, and lung nodules. The importance of identifying this, as Atul mentioned, is, and also Subha, is that you want to differentiate this from progression of disease. Lastly, this is a patient with glioblastoma who was on bevacizumab. It's not an immune checkpoint inhibitor, it's a targeted therapy, but this patient presented with avascular necrosis of the femoral heads. Okay, I'm gonna conclude. Immune checkpoint related or immunotherapy related adverse events are commonly encountered on surveillance scans. Radiologic manifestations are important to identify because early identification of adverse events is critical for prompt management, and imaging allows prediction of severity and determining outcome in these patients. So thank you for your kind attention.
Thank you, Dr. Avinash. Do you have any questions for the speakers? And thank you, Dr. Subba, for giving this toxicity session. It's very important that we know the history of drug that is received or any treatment for that matter in oncology, and should not be reported in silence. Do you have any questions?
Thank you, Dr. Avinash. We have a question, a common question to both the speakers, but the answers may vary. At what point of time should we, this is here, at what point of time should we withhold when there is a suspected toxicity? And also, what are the challenges in again introducing the drug after the patient has recovered from the toxicity?
That's a great question, and I wish I was an oncologist to answer that question. But see, as a radiologist, of course, your role is to identify the abnormalities and describe it. and also, call the oncologist and let him know that, this is what I'm seeing is likely related to the drug. But I think the decision is often made based on the patient's clinical condition, the severity of symptoms, as I showed you, the scale of severity, and also they often want to confirm that this is, of course, an immune-related adverse event before they either discontinue therapy or start the patient on some sort of immunosuppressive therapy. I think it's more of a multidisciplinary discussion at that time. So what happens is, if there's a patient who presents with cholangitis, the oncologist then involves the hepatobiliary surgeon, involves the gastroenterologist. They do an endoscopy before they stop the treatment, because these are often patients who have advanced disease and they are on immunotherapy for a reason. Yeah.
The answer is twofold. You have to first consider the severity of the drug-related adverse event or pneumonitis in the lungs. If the patient is asymptomatic, if there is response to therapy, it is usually the practice for oncologists to continue the drug. It's an informed decision. They tell the patient to seek out immediate attention if there's any respiratory symptom. If the drug is working, you want to continue it. Grade 1 asymptomatic, grade 1 pneumonitis is pretty common. If you take some of the MTAR, incidence is around 40%. For ICIs, incidence around 20%. Just because somebody developed doesn't mean that you have to stop it. But there are other types of pneumonitis. They are called as pulmonary eosinophilic pneumonitis. That is very common with osimertinib. It resolves on its own, even when the patient is put on treatment is continued, resolves. So there is a spectrum of this pneumonitis, and what is the pattern we are seeing? Whether it is immune checkpoint related, whether it's an mTOR inhibitor, is a ALK inhibitor, EGFR inhibitor, each has its own profile. So the oncologist has some understanding as to what is the severity of pneumonitis in the particular TKIs or immunotherapy agents. But if you're using antibody conjugates, which are the newer drugs which are being developed, they are more toxic. So if the treatment is not working, if patient has pneumonitis, you might as well stop it. But if the patient is responding, early pneumonitis, asymptomatic pneumonitis, it's an informed decision. The other, as Avinash has pointed out, whenever there is a ground glass opacity or a consolidation in the lung, the first thing is we have to rule out infection. The patient could have come in contact with somebody with flu or some other stuff. We have to rule out infection. We don't want to stop the drug. And when to start the drug, it is not very clear. Most of the time, people give a break, then restart the drug. Sometimes without steroids or sometimes with steroid cover. And can start the drug with a lower dose also to see if it is coming back. But these are all delicate decisions. If no other treatment is available for the patient, this is the only treatment, they might as well try whatever they can. The oncologist, I'm sure, would have better input in this regard.
Unfortunately, we both are radiologists.
Oh, okay.
And if my understanding is correct, there is criteria clinically to assess the patient on therapy, like CTCA guidelines there for clinical assessment, but there is no unanimous guidelines for radiological progression. Like, we cannot say that this is mild, moderate, severe, but you showed some guidelines for pneumonitis, mild, moderate, severe. Grade 5 is lethal, something like that.
Like Avinash has pointed out, for example, somebody has got a diffuse colitis. That's obviously pretty severe.
Yes.
Somebody has got diffuse alveolar damage that is very severe. So we want to not miss these things. So these patients invariably will be symptomatic. So symptomatic patients with extensive disease distribution on imaging would indicate it's a severe pneumonitis or drug-related adverse event.
Yes. I have a question. So understanding the toxicities is one point. Recognizing them is one point. Second important challenge for a radiologist, documentation. So let us imagine two scenarios. In the first setup, we are in the workstation. We know that there is a particular toxicity or particular complication is there. We definitely show that that can be attributed to some treatment like radiation or surgery, something. Now, how explicit we can mention or document that in the report? Because MDT meeting, we can talk directly, we can make a communication. But how explicit we can? Because in the era of ChatGPT and not in Google, they can get even more details. The patient can get more details on their own terms, so they can understand more easily and everything. So how we can go with that? My second question is, the scenario is, even we are not sure about it. We are little that the colitis is really drug related or infectious. So in that kind of scenario, how to document, how to phrase the uncertainties in our report, uh, not to overcall or undercall, how to balance out.
That's a very interesting question. If the patient is on a clinical trial, any adverse, any drug-related event is reportable. We have to report it to the clinical. You have to report to the IRB. You have to report to the pharmaceutical company. Whatever it is, yet it is to be reported. For that particular reason, if you're not sure, always say it could be infection. However, drug-related pneumonitis can also have similar appearance, because most of the time, we don't never be sure. So you can always say that it could be infection, but always there's a possibility that it's a drug-related adverse event. That is important because it's a reportable event. When you think about it, clinical trial setting, sometimes that is to be reported to the FDA for drug approval, especially for protocols which are being approved. It has to be reported. We cannot say we cannot report it. As to how the patients react to it, the oncologists react. I'm sure when they're being enrolled into the trial or when the newer drugs are being administered to the patients, that the oncologist would tell them that they may develop symptoms, and when they develop these symptoms, they should report promptly. So I don't think even if the patients are looking at GPT, they'd be surprised, because it should be an informed decision process. What do you think, Avinash?
Oh, I totally agree. I mean, as Suba was mentioning, those patients who are on clinical trial or even on immunotherapy, actually the oncologists are actually more aware of these complications than us. They are actually looking for this. And as Suba mentioned, patients on clinical trials, they are very tightly regulated. So any adverse events have to be reported. The FDA is pretty, they sometimes do audits and they go through the EPIC chart. So even a slight mention of immune-related adverse events, colitis, they want to check on that. So what I do is, for example, if I say a patient who has colitis, what I do is I describe it in the body of the report. In the impression, I meant CT findings of colitis. I describe span colitis, isolated involvement of sigmoid colitis. Then I say differential diagnosis, infectious or inflammatory. And I talk to the provider. And then they make a decision. Because as Suba was mentioning, colitis can be due to different, we've had patients where colitis looked like immune checkpoint related colitis, but patient had CME colitis, right? Patient could have CD colitis. So that's why imaging findings are non-specific, so you can give the differential, let the provider decide.
Yeah, thank you. I have one quick question to Akbar. How often do you come across cardiac toxicity? Because more and more prior to treatment, it's the protocol that the patients will undergo cardiac evaluation and everything. They even do Muga scans, echo and Muga scans as part of the workup. I'm trying to push more and more cardiac MR. This is now oncocardiac MR imaging is becoming more and more. What's your experience with cardiac toxicity with most of this, whether it's drug or radiation?
Yeah. There are some drugs which are particularly known to cause cardiac toxicity, like doxorubicin and adromycin. They are caused. So those patients usually get periodic cardiac ultrasounds, echocardiography to monitor their cardiac myocardial function. But for other drugs, the cardiac toxicity is actually a more indirect sign. Patients usually develop myocarditis, some sort of congestive heart failure. So we see on the chest imaging pleural effusions, pulmonary edema-like picture. Then we say probably this is myocarditis. Again, the problem with myocarditis is non-specific. These patients are elderly, whether it's a stress-induced ischemic process, underlying coronary artery disease, or it's a drug-related toxicity is difficult to say. These patients can also develop pericarditis because of viral infections. So it's difficult to say. But fortunately, in our experience, the drug-induced myocarditis is not that common. Though it is described with almost all the drugs, including immune checkpoint inhibitors, they are not common. When they develop, they're pretty serious. So we had to stop the drug. But a few cases I know, the myocardium tends to recover. So that's good.
you. I mean, amyloidosis is one entity which even the hematologists keep asking for us to do the assessment.
I would not do too much of imaging if you think it is cardiac myocardial toxicity, if the cardiac enzymes are elevated, if it looks like clinical picture is consistent with myocarditis, some pulmonary edema. We would not do any MR or anything because most of the time it recovers. If the patient continues to have symptoms, then probably at that time MR would be probably useful.
Thank you so much. Thanks for your sessions. So in a nutshell, radiologists should be aware of the drugs, and we should spend time on each case before we put it on the report. Talk to the clinician. So we'll end this session.
Thank you so much, Dr. Avinash and Dr. Subha, for a very good discussion. We would like to thank our chairpersons for gracing the occasion. So that comes to the end of a session.